Yeah. Hello, good morning. That sounds fine. Yeah, it's okay.
Most of it, yeah. being on television. Good morning, everybody, and welcome to the Blackrock Clinic Study Day. We have a very good lineup this morning. We'd like to welcome everybody here who's dressed and all those who are sitting at home in their pyjamas watching us on the webinar. Blackrock Clinic has once again come up with a great line of speakers. I'll introduce each speaker now, if you don't mind, and then we'll take questions at the end of each talk. Because it's a webinar, people will be sending questions in. None of you are on the webinar. You're not being videoed, just in case for GDPR reasons you won't. But if you have questions, your voice will be heard. And then later on, these webinars are actually put up on YouTube, which you can have a look at later if you want to recall any of the points the speakers made. So first up, we're going to have Mr. James Ford. He's a consultant urologist who does a lot of work in pelvic floor reconstruction. He will touch on what is now a very controversial topic, the use of taping and transurethral tape and transvaginal tapes. So he will touch on that and give us some insight into that, because I'm sure we're all hearing from patients the problems that they have. Then Aoife Clark, who is a senior physiotherapist who's a specialist interest in pelvic floor as well, will speak to us both about the male and female pelvic floor and the work that she does. Unfortunately, Dr. Kushal Chuman will then speak with us. He's a consultant gynecologist. Today he's going to address endometriosis and endometriosis surgery for us. And after Dr. Kushal is Professor David Gallagher. Unfortunately, is unwell. So his colleague, Dr. O'Hany, Mr. O'Hany is going to speak to us. He's a genetic counsellor, and I think given all the questions we're now receiving about genetics and genetic screening, it's going to be something that's very topical for all of us as GPs. I just ask you all, if you have a phone, either please discern it onto silent or switch it off, just so we don't interrupt the speakers. And at the end of each talk, we'll take questions. So I hope everybody enjoys the morning and we get a lot out of it. I hope you all got your little CME cards, and don't forget to go to the ICGP Professional Competence and log your points. Okay, everybody, so without further ado, Mr. James Ford will speak to us now. Thank you.
Good morning, everybody. Thanks for coming. I've been asked to talk on a specialist interest of mine, which will be urinary incontinence. We're going to go through, I suppose, the particulars, the main conditions: overactive bladder, stress urinary incontinence. Barbara mentioned I'm going to touch on a very recent controversial topic that has occupied a significant amount of my time over the past number of months, but hopefully to a good outcome. So a little bit of background. James Ford is my name. I'm a UCD grad. To cover my bases, I went to Trinity for my MD, and I did my urology higher surgical training here in Ireland, and I then went on to New York to Cornell to do a fellowship in voiding dysfunction. So my main interests, aside from general urology, stones and those kind of things, would be female voiding dysfunction, in particular female incontinence, UTI, prolapse, and then male voiding dysfunction, such as in particular BPH, and then post-prostatectomy incontinence. So incontinence can be broken down into different types. We have our urge incontinence, stress incontinence, mixed incontinence, and occasionally you might see overflow incontinence, particularly patients in chronic retention. Stress incontinence makes up the predominant amount, almost 50%, urge are less, and there is a mix in between. But in reality, this is the kind of picture that I'm sure you guys face in patients with a little bit of everything, and it's very hard to differentiate what type of incontinence they have exactly. So when I get referred a patient with incontinence, as I'm sure you do, I generally start with basics such as urine dipstick, send off a urinalysis, a bladder diary, a flow test, and a cystoscopy and urodynamics if necessary, but I'm going to be touching on those in more detail later on. So firstly, I want to talk about the urgency incontinence, or in particular overactive bladder, which would be labelled as. Now, the International Continence Society, which we have an annual meeting of, would define overactive bladder as a symptom syndrome, suggesting lower urinary tract dysfunction. And it comprises of urgency. Oh, sorry, you haven't got the slides. I'm sorry. Sorry. So overactive bladder arise from detrusor overactivity. And when we talk about detrusor overactivity, that's actually urodynamic diagnosis. And that's, as you see there in the bottom left, where we get contractions, involuntary contractions in the bladder. And why that happens, we're not exactly sure. About a third of patients, really the detrusor muscle itself just decides to contract at different volumes. We think it's an isolated cell portion called a global contraction. But I had the opportunity when I worked in New York. Sorry, is it up down? Sorry, skipping a slide there. I'm not sure. Blackrock. Yeah, it's not coming up. Anyway. I'm sorry about this slide's not coming up. Really, one of the big problems with overactive bladder, and Jerry Blades, who I worked with in the States, would have a big bugbear about it, that it's labelled as a disease and patients are labelled as having overactive bladder. In reality, that's actually only about a third of patients. The vast majority of the patients actually have either UTI, prolapse, maybe have a neurological condition. So it is vital that you look and try and outrule all other potential causes of overactive bladder symptoms. So when I get a patient with overactive bladder, I work through the algorithm. You start with the basic, the medical history, the physical examination, and then moving on to the various treatments that I'm going to touch on. Aoife as well, in particular, is going to focus on the physiotherapy, and then I'll talk about some of the newer medical and surgical managements. So behavioural modifications really are key. We all see patients who drink umpteen cups of tea a day, and it's very hard, particularly with Irish people, to get them to cut that down. And we have such good evidence that if you just reduce your fluid intake, your symptoms will improve. By doing something like a bladder diary, it's often like a little bit of homework for the patient, and really once they see how much they're drinking, they do get a little bit of a shock, and often they can almost curtail their habits and improve their symptoms significantly. And some studies have shown that behavioural treatments can be as effective as medication in some patients. So when we talk about other particular different behavioural treatments, it could be timed voiding. So this is when you get a fixed interval between trips to the toilet, and what you're trying to do is relearn what the patient learned in infancy. That they, once they get the urge to go to the toilet, that they try and delay that and then increase the time frame that, to increase the time between voids. Also, that when you get bladder training, when they get the urge to go to the toilet, that they maybe do a pelvic floor contraction and just try and let that urge dissipate, again allowing an increased capacity, and over time you would hope that their bladder capacity would increase. So what about conservative treatments? Well, weight is always an issue we have to approach. We do know, as with most illnesses, weight can have a significant impact. And there was a study published in the New England Journal of Medicine showing that even a 5% reduction in weight loss can have a 50% improvement in your urinary incontinence. So we would often see dramatic improvement in patients once they embark on weight loss. Fluid intake that we mentioned before is key. Reduction of fluid, particularly of particular fluid types of caffeinated drinks, will lead to improvement. Carbonated drinks. Some nice studies recently actually on diet drinks and the sweeteners that they have in them can actually cause detrusor contraction. So again, I ask patients to try and limit carbonated beverages. And then caffeine. I mean, 50% of patients who take more than 300 milligrams of caffeine a day, which some patients would easily do over the course, can suffer from overactive bladder type symptoms. So when we talk about medical treatment, really what you're trying to focus on is the receptors in the bladder. So detrusor contraction is mediated by muscarinic receptors or anticholinergic receptors. So there's M2, M3, and really what you're looking to do is inhibit them and prevent contraction. The new kid in the block, betmega, which I'm sure you've heard a lot about, targets the beta-3 adrenergic receptors, and it works actually really differently. It promotes relaxation of the bladder. I'm sure you're all familiar with the different names of the antimuscarinics that are out there, and essentially, to cut to the chase, they all are roughly the same. There's been meta-analysis done on large scale shown that they're effective in approximately 50% of patients. And one thing that I'm sure you see probably more than us is the discontinuation rates. They're not pleasant, some of the side effects of these: dry mouth, constipation, blurred vision. So there is evidence saying that up to 60% of studies of patients can discontinue them at a year. So it's something to bear in mind. Mirabegron, or Betmega, which touched on, is the newer one, and really that's been heralded as the side effect-free tablet. It seems to act equal efficacy to an antimuscarinic, but you do have to be aware in patients with a history of hypertension. That is one of the known side effects. But again, data is emerging that patients do discontinue then at a year's time, but the side effect profile appears to be less. I would do a lot of combination treatment, so if a patient has maybe started on an antimuscarinic, has had no improvement, I might add in Betmega then, and we have some nice studies coming through. Traditionally, we would have increased the dose of the antimuscarinic. When you do that though, you can increase the side effect profile, so by combining the two, hopefully you reduce that side effect profile. And what happens if that fails? Well, there are a large proportion of the patients that we get that have been managed in primary care, but they're still not getting symptom free. So Botox, it's used pretty much everywhere else nowadays, but we use it a lot in the bladder, and it is very effective. Up to 70%, 80% in some studies, symptom improvement for patients. And it lasts about 6 months, which gives patients great relief. The problem we always have to discuss with patients is urinary retention. About 10% of patients won't avoid after Botox, particularly after 2 weeks later. So it's something we bear in mind, and something when I talk to a patient, I say, well, would you mind catheterizing for a couple of weeks? Some of them say, no way, and they're happy to continue the tablets, but others go, I don't mind, I'll do anything at this stage. Something else that I offer patients is sacral neuromodulation. This was very common in the States, and starting now to hopefully increase the use in Ireland. There was only 2 of us doing it in the country till recently, but I think unfortunately the only person now doing it for urinary symptoms. So what that is essentially a pacemaker for your bladder. And what that involves is putting a trial lead in through the S3 foramen, externalizing the lead, and then the patient keeps a bladder diary for 2 weeks. If they meet a 50% improvement in their symptoms, we will insert and internalize the lead with the pacemaker style battery. And those batteries have a life for about 7 to 8 years, so I have a lot of younger patients in their 30s or 40s who really get great comfort with this. And I think it's something that as technology improves, the new battery out next year is going to be even smaller. Unfortunately, it's not MRI compatible at the moment, which is a problem, but they expect that the next generation next year will be MRI, so that might change things slightly. Previously, before these, we relied on major abdominal surgery, such as augmentation cystoplasty. I've done a handful over my training and career, and really Botox, sacral nerve modulation have dramatically reduced the amount of these surgeries done. Because one, they're not straightforward, but also they're huge for the patient. You do a bowel resection, you split the bladder and place a segment of bowel on top. The patient most likely will have to self-catheterize afterwards and get increased mucus production. And it's a huge amount of morbidity for essentially what is a benign condition. But there are still some patients that may require it, but they're few and far between. So now I'll just move briefly on stress incontinence, and we'll talk about some of the issues related to that. Well, that is involuntary leakage, effort and exertion. And Aoife's going to talk about this, but it's laxity of the pelvic floor muscles and dysfunction of the bladder neck. So increased abdominal pressure, increased leakage of urine. So we've touched on a lot of this, but stress urinary incontinence, the history can really tell an awful lot. First of all, I'll tell you the type. of incontinence. We sometimes get our index patients that literally, I leak when I go for a jog, and that makes life pretty straightforward for us in terms of assessment. But then we have a lot of patients who are getting up at night, and also patients who are so worried about leaking with exercise that they make sure they go to the toilet very frequently. So then they're starting to develop sensitive overactive bladder, and it kind of confines everything like we talked about in that diagram. The severity of the incontinence can often be dictated by pad use, and sometimes we would do a pad test where we weigh the pads, because some patients would keep a pad on long on, others, some would change it with literally a drop. So it can be hard to actually ascertain exactly how much leakage, but by doing a defined weight of the pads. We would always give a questionnaire to see the impact on the patient's lifestyle, and then that allows us to see if our treatments are effective. Previous treatments, concomitant bowel dysfunction is something that is also can be commonly seen with patients, as well as their obstetric history and the type of pregnancy and type of delivery. In terms of patients who are nulliparous, obviously the lowest rate of stress incontinence, but even patients with cesarean section due to having a pregnancy can develop quite significant stress incontinence. And then there's a further slight increase for vaginal delivery. Menopausal status is important, as is the relative medical history and also medications that they're on. So on exam, common things, you look for a palpable bladder. If someone's got maybe suggestive overflow incontinence, it could be that they're in chronic retention. Also vaginal atrophy, and some then go hand in hand. An elderly patient with very, very severe vaginal atrophy can actually develop bladder outflow obstruction as a result, and underactive bladder. I do a cough and Valsalva manoeuvre just to see the degree of leakage. I look for a hypermobile urethra. I'm not sure if you remember the Q-tip test or ever heard that, but that is where you get a large swing where the urethra, because it's not supported, there's significant movement. Otherwise you might have an intrinsic sphincter deficiency where it's almost like a lead pipe urethra where the urine is just pulling out. You look for prolapse, particularly a large cystocele. Sometimes that can actually mask the incontinence, so I would reduce the cystocele, then get them to cough, because if you do an anterior repair for prolapse, I'm sure Kushal will agree that sometimes patients come back and say, well, now I've developed stress urinary incontinence. It was always there, it's now that you've restored the floor, it's something that will need to be addressed. We look at the pelvic tone, the sensation, and then we work through the investigations that we mentioned before. So what about treatment? We talk about conservative weight loss, is again key for these patients. We have some patients that really, with significant comorbidities, and I'm sure you've seen this, and unfortunately some patients end up with something like urethral catheter, it's so hard to use, or continued pad use, and that can often, be the mainstay of treatment. Aoife will touch on pelvic floor exercises, so I won't steal her thunder. And medical treatment, topical estrogen is not a cure for stress incontinence, but it will definitely improve the vaginal tissues, and it will definitely improve the overall condition of the tissue, and also internally it helps with the urethral mucosa, and that in turn again could help reduce the stress urinary incontinence. Duloxetine is an antidepressant, but with the side effect of increased pudendal nerve activity, so it increases sphincter tone, and that is something that is used sparingly. When I worked in the US, it's actually not licensed over there. One of the big problems is the side effects. About 40% of patients get bad nausea from it, and the success rates of treatment have only been 40% of patients respond. And finally, we'll talk about surgical. Aoife will touch more on pelvic floor exercises, but really the mainstay of treatments has been, for us, we use urethral bulking agents, which you can see there on the right, and that is an injection into the urethra. It's almost like a filler, which reduce the lumen. They've been around for 100 years. They've tried everything, and they're slowly getting better, but they're probably an efficacy rate of 50 to 60%. They're increasing in use, sometimes in patients who may be planning future pregnancies. We've got some emerging data on that. Urethral slings, either synthetic, either a TBT or a TOT. And then another type of sling called an autologous sling, or rectus fascia sling, that I do and I'll touch on. The old standard of care was a colpoid suspension, which involved an open operation, basically hitching the urethra up to the pelvic sidewall to prevent that hypermobility. We have some patients completely refractory who have gone through every treatment, and we ultimately end up doing a urinary diversion, the ileal conduit. Again, it's uncommon that we need that. I just want to touch recently, we're getting inundated with vaginal laser inquiries about treatment. It's something I'm a little concerned about. The FDA have issued a warning on the use of vaginal lasers. There's zero evidence for stress incontinence. Maybe emerging for vaginal rejuvenation, but in terms of stress incontinence, we don't have any evidence, and it's something we're seeing a bit more in the community. And some centres often have to amend their advertising as such. So just focusing on urethral slings, TVT and TOT have been the mainstay of treatment for about the last 10 to 15 years. And the TVT is what I do, and that involves a retropubic, so it's a synthetic tape. Essentially it's proline suture material woven into a lattice, and it's passed below the urethra behind the pubic bone. The TOT came out later, and that involves going through the transobturator foramen. They both have equivocal outcomes, but we have up to a recent study, actually 17-year data. But generally, the biggest papers is 13 years follow-up, showing about a 90% success rate. They do come with their complications, and about a 1% erosion of the tape, probably about a 10% what I would call de novo overactivity, where the patient, when they're no longer leaking, now has storage symptoms. And sometimes patients actually can develop urinary retention, and with 160 slings I've done in the past 2 years, I've had to cut 2 of them for patients that didn't void afterwards, but they returned to normal voiding afterwards. So they'd be the key with the TVT. The TOT would have a slightly higher rate of pain issues because of where it goes through, so chronic pelvic pain. But again, 1 to 2% is the documented rates. So autologous slings are the other type of sling that I do, and that involves taking a piece of the patient's rectus fascia from their abdominal wall and using that as the sling material. He actually uses proline suture material to fix it in place of the abdominal wall. And prior to the synthetic sling, that was emerging as probably one of the more common treatments. It's a big day out for patients. They're in hospital for 3 or 4 days. It's essentially a C-section scar, but it does work very well. But it does have, in certain respects, some of the complication rates can be higher. The voiding dysfunction afterwards can be higher. The urinary retention rate can be higher. And my practice in rectus fascia slings is predominantly in patients who have had a failed synthetic sling and really are, quite miserable. And you do counsel them that there may be a need to self-catheterize after the procedure, but the majority don't need to, but it's something you do need to discuss with them. I'll go briefly on to the vaginal mesh controversy, because I'm sure you've all heard about this. This all kicked off in the States in 2011. The FDA released their white paper documents. They have their MAUD database, which is adverse outcomes, which anyone can submit a complaint to, showed a concern for pelvic organ prolapse mesh. And there was a Cochrane review showing that these increase in these kits, the prolapse mesh kits you see are at the top of the slide. And it's actually quite a substantial amount of mesh. It's the same as a hernia mesh, and it involves arms going through to support either a cystocele or a rectocele. They exploded in use because the kits were quite easy to put in, and many companies started promoting them, and their growth in the US dramatically increased. A Cochrane review subsequently came out showing that they may not have a benefit compared to traditional repair, but also that the erosion rate of the mesh was about 10%, so it's about 10 times higher than the sling below. So they reclassified it to a grade 2 device, which would be high risk. And because the synthetic sling was part of the vaginal mesh family as such, that got drawn into the controversy, although with the lower complication rate. But the FDA did say that they were happy with the outcomes, but there was key that the surgeon needed to be trained in the procedure and able to manage the complications. As you can expect, and I worked in the States at the peak of this in 2014 and 15, it exploded. And you couldn't go buy a TV without an ad or a magazine or just something saying, have you had mesh? Please talk to your lawyer. And massive payouts, a huge amount of payouts. And it became more and more into public controversy. In fact, some companies then discontinued making all products, and really we're kind of left with three of the main companies now at all. It then spread onto social media, a lot of blogs set up, and these were patients who probably had genuine did have genuine complications, but I suppose there's a platform now that the information is out there now to see. And one that I came across, I remember when I went to write a review in the US for this, was on the link between mesh and autoimmune disease, and there was a lot of concern in the public that we actually had done a review through the American Urology Association. There was no link between autoimmune diseases and mesh. Mesh for hernias, it's all the same, but it's very hard to dampen down that once it's out there. So then it jumped across the Atlantic, and the Scottish Mesh Survivors Group was the first port of call that took this on. And they lobbied their local MP, who overnight suspended the use of all vaginal mesh, both for prolapse and incontinence. And that kind of left surgeons in a position where they have multiple patients lined up for surgeries, and they had no option. Then the media and Sky News and the Daily Mail in particular ran some very aggressive campaigns, and these were, I suppose, women with genuine complications, but the majority of women who had successful outcomes were very scared, as you would be reading a lot of these headlines. So the NHS, after the Baroness Cumbridge report, she did a review, and she advised a pause on the use of vaginal mesh. Prolapse had initially been suspended, and then for incontinence. And the idea would be, and we'll talk about that, some concerns would be addressed, and I think that would be for the better, but I'll mention what they are. As we do in Ireland, we followed on a couple of weeks later, and I'm the College of Surgeons representative on the advisory panel for this to discuss the future of it. And so Simon Harris has announced a pause in the use of midurethral slings, and that's left us in a bit of a situation. I know in Beaumont alone I have 75 patients on the waiting list for a midurethral sling, and we've, as a result, had to pause all stress incontinence surgeries, so we've no surgical treatment to offer those patients at present. But the recommendations that are coming from the panel and kind of mirror what has been published in the UK, that it's important that the surgeons who undertake these procedures are appropriately trained and that they do it regularly. You need to be doing a lot of it to be good at it. And every procedure will be performed to a database, and similar to the HIP database that occurred a couple of years ago, that is something that is going to be proposed. There'll be a register that if a patient does get a complication, you know where they had their surgery, what type of surgery, and the operation that will be available. And also that we identify specialist centres where the complications can be dealt with appropriately. And also that appropriate guidelines. So the future, well, currently the UK and Ireland are the only two countries in the Western world who's put this suspension in place. The Americans have been very clear with the FDA backing that prolapse mesh probably doesn't have a future. And the general consensus would back that, given the higher complication rate. But the midurethral sling has been the most successful treatment for stress incontinence we've ever seen, and it's continued its use in the US. And I mean, one line that came from the American Urology Association that it would be a disservice to women who choose surgical correction of stress urinary incontinence. So again, they backed that appropriate training is important. The Australians recently made their recommendations again, where prolapse mesh probably doesn't have a future role, but again, trying to, I suppose, ensure that the midurethral sling is an option for women. So, it's currently a difficult situation for patients and surgeons, and we are currently unable to offer any surgical treatment for stress urinary incontinence. The midurethral sling is still the first line surgical treatment in North America, continental Europe, Australia, New Zealand, and is likely that pelvic organ prolapse mesh will be discontinued. The vast majority of patients do have a successful outcome up to over 10 years now, but it is vital that the genuine complications that happen, that these can be dealt with appropriately and in specialist centres. I think then hopefully that will go to address and then overall help the treatment of stress incontinence for the future. So thank you.
Okay. My name is Aoife Cullen. I've just recently switched over to my married name because we're getting registered with Forest. If there's any confusion, but I'll obviously accept all referrals under TARF or Cullen, whatever comes my way. So just to give you a little bit of background on me, I am a specialist women's health physiotherapist. I've been working in women's health strictly for about 3 years now, but I've been a physio for 11 years. I graduated from Trinity in 2007, and since then I've worked and travelled quite a bit. So I've worked in New Zealand, Australia, and most recently in Canada, where I've done all my women's health training. I guess as a women's health physio, it goes without saying that we're kind of moving more towards calling ourselves pelvic health physiotherapists, because we're slowly realising that the male pelvic floor needs some attention too. So while I'll largely talk about women's health today, I do see men's health patients as well, so mainly male incontinence, chronic pelvic pain, chronic prostatitis, and male post-prostatectomy. I'll also touch a little bit on bowel health, which is something that I cover and treat as well at the Blackrock Clinic. So my objectives today are to discuss the prevalence of pelvic organ prolapse and incontinence. Just for ease today, I'll refer to pelvic organ prolapse as POP. I'd like to discuss the functional role of the pelvic floor muscles, discuss evidence promoting pelvic floor exercises for prolapse and incontinence. I'd like to talk a little bit about physiotherapy assessment and treatment techniques, so there may be a little bit of a crossover with what James spoke about, but luckily we both are in agreement on it. And I'd like to, I guess, increase your knowledge and confidence in knowing when to refer to a specialist pelvic health physiotherapist. So, the prevalence of pelvic floor disorders, so that's looking at incontinence or pelvic organ prolapse as a whole, is about 40% of women in their 60s, and that increases to about 50% of women over 80. So it's estimated that about 1 in 5 women will have some form of surgery for either stress urinary incontinence or pelvic organ prolapse. The prevalence of pelvic organ prolapse on its own is about 5 to 10% of women, increasing to about 40% of women aged over 50. So I think that's when what Jane spoke about as well, those menopausal changes, vaginal atrophy, the vaginal tissues need estrogen to keep them nice and plump and healthy and keep everything in place. So often a lot of my patients start to have problems post-menopause. When that estrogen level drops, everything just gets a little bit more loose and a little bit more lax, and those problems start to come to a fore. It's been estimated that the lifetime cumulative risk of surgery for POP is about 7 to 11%. My Data for prevalence of incontinence is largely based on UK data. So they've estimated that about 40% of women in the UK suffer from incontinence. That's a mix of stress or urge incontinence, and it affects about 10% of men over 65. The NHS have estimated that between 3 and 6 million people in the UK have some degree of urinary incontinence. In Ireland, it's estimated that it affects about 1 in 3 women, but again, it's hard to find good quality data on this at the present time. So just speaking a little bit about bowel incontinence, that's something that I treat as well. It's difficult to find good quality data. I think truly it's probably not that the evidence isn't out there, but it's underreported because often it's a condition that people have a lot of fear, a lot of embarrassment about. It's hard to know who to talk to. A lot of patients think they're the only one that's suffering with this, so often they just keep it to themselves. It has been estimated that it affects about 2 to 24% of community dwelling adults, and this is evidence from Australia, with about 1 to 2% of patients experiencing significant impact on their daily activities. So there's been some data out of the US looking at a claims database from 2007 to 2011. It was about 10 million women that was on this database, a really large study, and they estimated the age-specific incident rate and cumulative incidence of stress urinary incontinence surgery, POP surgery, or a combination of both was about 20%, so that brings it back to your 1 in 5. Another study from Australia, Western Australia, is in the same kind of range. They estimated that the lifetime risk for POP or stress urinary incontinence was again about 19%. They concluded that there is a relatively high likelihood that a woman in Western Australia will undergo some form of surgery for POP in her lifetime. And what I really like is they concluded that this is justification for a stronger evidence base for prevention, early detection, intervention to reduce the personal and societal costs of these gynecological problems. And really, as a pelvic health physiotherapist, that's what we're aiming to do on a daily basis. So I know that pelvic floor exercises can strengthen the pelvic floor muscles to help support and prevent pelvic organ prolapse, but I'd like to talk you through a little bit about the role of the pelvic floor and where it is and what it does. So for some people it can be an area of confusion. So the pelvic floor is a whole group of bowl or dome-shaped muscles. There's really about 40 muscles actually that attach into the pelvis as a whole, but when we talk about the pelvic floor, it's really just that deeper group of muscles. So it comes from your pubic bone at the front, back to your tailbone, and then it flares out to your 2 sit bones. So it's a diamond-shaped muscle. And really it has 2 functions. It's got to close around the bladder and the bowel to keep us continent. Obviously it's got to open for bladder and bowel motions as well, but its other role is to lift and to support the pelvic organs. So touching a little bit on what James talked about, the role of the pelvic floor in supporting the bladder. If you imagine that the pelvic floor is not as strong as we would like it to be and not giving that adequate closure pressure, if there's any increase in intra-abdominal pressure when we cough, when we laugh, sneeze, jump, that increase in pressure can result in leakage unless the pelvic floor is strong enough to switch on to close around the sphincter. So that's really talking about your true stress urinary incontinence. Again, I have to do a lot of education in my role because we can't see our abdominal contents. A lot of patients don't really know how everything's held up in there, how everything works. So a model that I like to use a lot is Delancey's analogy. He talks about the pelvic organs like a ship on the dock. So if you think about your bladder and your bowel as the ship, if all those strong supporting ligaments that hold everything in place are the ropes, and the water is your pelvic floor, if the pelvic floor is strong, it's going to help hold the bladder, the uterus, and the bowel in place. It's no strain on those ligaments or those ropes, and everything stays where it's supposed to be. If the pelvic floor is weak, and we do a lot of chronic coughing, if we're straining for a bowel motion, doing a lot of heavy lifting, all that force is transmitted down on the pelvic organs. Those ligaments and supportive structures get stressed or strained, and that's when we can lead to prolapse. And for some patients, it really can be that straw that broke the camel's back moment. So I've had patients who said, I just took the Christmas tree down from the attic and I just felt something drop, or I went to lift my grandchild and I felt something coming down. So if your patients are complaining of those kind of symptoms, it really is suggestive of a prolapse. So again, if the pelvic floor is weak, it's not able to do its supportive role, which is to lift up and support against that downward pressure. and really it just leads to everything getting loose and dropping down. So as a physiotherapist, we're really guided by the NICE guidelines, and the most current guidelines for urinary incontinence came out in 2013. So they suggest that you should offer a supervised pelvic floor muscle training as first-line treatment to women with stress or mixed urinary incontinence. And really it takes about 3 months of really sticking consistently with the program to see improvements. So I do tell patients I have to teach them what to do, but then they really need to do the hard work. Obviously, if it's a supervised program, it's more beneficial because patients are more likely to stick with the treatment. These recommendations are also in line with the International Continence Society guidelines from 2015, which also recommend physiotherapy as first-line treatment for stress urinary incontinence. For fecal incontinence, the NICE guidelines came out in 2007, and they've been reviewed and updated in 2018, so very recent. They say that people who continue to have episodes of fecal incontinence after initial management should be referred to a specialist health physiotherapist for pelvic floor training, bowel retraining, specialist dietary assessment and management. A lot of my patients will have some form of dietary or lifestyle habit that is not helpful to their condition. So working within my scope of practice, I'll often give the patient basic dietary advice, but luckily enough at the Blackrock clinic we do have a gut health clinic that's run by our dietitian Lorraine. So I'll often refer a lot of patients onto her, because unless the consistency of the bowel is improved, I'm kind of fighting a losing battle, and so is the patient. So it's working together with the dietitian on that. Some other adjuncts to treatment that we use are biofeedback. Electrical stimulation, really as per NICE guidelines, any kind of electrical stimulation is only of benefit if the patient is very weak or can't maintain a contraction at all. So again, for fecal incontinence, a patient-specific exercise regime is most beneficial. It is important that we do a digital rectal exam so that we can monitor their progress and grade that strength of pelvic floor contraction and see how that improves through the treatment protocol. For me as a physiotherapist, the most practical grading scale that I can use is the Baden-Walker prolapse grading scale. That goes from 0 to 4, with 0 being no prolapse and 4 being complete descent or inversion of the bladder, bowel or uterus. Most commonly used by our gynecological colleagues would probably be the pelvic organ prolapse quantitative grading scale. But again, it is a little bit more complex, so I find the Baden-Walker that little bit more patient-friendly. I mentioned the POPQ because it was used in a recent study from 2010 that looked at seeing if pelvic floor exercises can help to reduce prolapse symptoms. It was a randomized controlled trial with 109 women, so not a huge trial, but again, it is difficult to find good quality data. I think the more that we're learning, the more research and the more investment that is being put into these studies. But until then, we're kind of focused more towards smaller studies. Similar to the treatment that I would instigate with these patients, they split patients into a group of learning pelvic floor muscle training, doing the NAC, which is a pre-contraction before you cough, which again automatically teaches your pelvic floor to switch on before you cough, laugh, sneeze, with a home exercise program. And they found that about 19% of women in the intervention group improved by at least 1 grade of their pelvic organ prolapse versus 8% in the control group. Now the control group did get some information on diet and lifestyle intervention, which may have helped with that. Interestingly, compared with control, the intervention group had a significant elevation to their bladder, a non-significant elevation to the rectum, and what I really like is they had reduced symptoms of frequency and bothersome of their pelvic organ prolapse. So in conclusion, they found that pelvic floor muscle training is without adverse events and can be used as a treatment for prolapse. Another recent study done in New Zealand and the UK looked at if pelvic floor exercises can help prevent progression again of your prolapse. Now they were looking more again on the symptom side of things rather than actually grading their prolapse. Their treatment regimen was similar to what we would instigate They gave patients a one-on-one pelvic floor training program of about 5 sessions over 16 weeks. So again, mostly I need to, number one, get the patient to learn how to contract their pelvic floor, where their pelvic floor is. But then really I'm not seeing them for a very long length of time. I send them away, I teach them what to do, they have to do it, get them back, reevaluate it, and then make it more functional and more appropriate to their lifestyle, the exercise program. They found that for women in the control group, their symptom score stayed the same, but improved for women in the intervention group. And I think this is really important because for my patients, it doesn't really matter if I tell them that, oh, you were a grade 3 and now you're a grade 2, you're a grade 2 and now you're a grade 1. That doesn't really mean anything to them, but if they can come in and they can say, well, I used to feel that there was a heaviness or a bulging every time I lifted my grandchild. I used to be afraid of gardening, now I'm not. I had to give support to my perineum to empty my bladder. If that improves, I think that's really what makes a difference and that really what makes my job worthwhile. So, in summary, pelvic floor muscle training for a POP can reduce bother and frequency of symptoms. It can reduce your symptom score. It has been shown to elevate the bladder and the rectum. It's effective in reducing symptoms and is without adverse effects. So as GPs, you'll know that they say laughter is the best medicine, but unfortunately not so much if you're incontinent. So that's what I want to help my patients with. So a little bit of information from a systematic review that looked at pelvic floor muscle training as its main intervention for stress urinary incontinence found that patients with a higher pelvic floor muscle activation and strength components positively influence continence. So continence women had a better pelvic floor muscle activation, maximum strength, mean strength or sustained contraction compared to the controls with stress urinary incontinence. So again, that's all in favour of having that first line intervention. Delancey again studied the relationship between the pelvic floor and pelvic organ prolapse. So they found that a 43% incident of reduced pelvic floor muscle strength and muscle atrophy among the group with pelvic organ prolapse compared to their controls. So again, I guess I'd like to talk a little bit about physiotherapy management. That might be the part that you're a little bit unclear about what we do. I tell most of my patients it's kind of the secret side of physio that no one knows about. So, for me, I get an hour with all my patients. Sometimes I'm prone to run over that, but it's really important that I give my patients time and a compassionate ear. I want to know what their understanding of the problem is. Again, similar to what James and Kushal would discuss with their patients, I want to know the past medical history. Their obstetric history is obviously hugely important to me. Dietary habits, bladder habits, bowel habits, their sexual history and any pelvic pain. And then objectively, as a physiotherapist, we still at heart are movement specialists. We take a holistic approach to the whole body. So we have to assess the hip, the lower back, the pelvis itself, especially if there is pain. Their posture, how you're breathing and how you're moving can also hugely affect your pelvic floor. More research is looking at, rather than just the pelvic floor in isolation, what we call the core canister. So it's your diaphragm at the top, your pelvic floor is at the bottom, your abdominal muscles are at the front, and your lumbar stabilizers at the back, and really how that relationship acts together to get optimum function to your pelvic floor, but also reduced stress and strain through your pelvic organs. So then, with the patient's consent, and obviously informed consent, so I spend time chatting them through what we're going to do using my model and using some visual aids. I'll do an internal vaginal or rectal exam, and what I'm looking for is sensation, reflexes, tone, muscle control, and their structural supports under a cough or under a Valsalva movement. So a lot of patients don't even know what their pelvic floor is, so I have to teach them, number one, what it is, where it is, then we move on to how they can contract it. I'll have a lot of patients that say, well, I tried pelvic floor exercises before, but it didn't work for me. And when we get down to what they did, they maybe lied down or tried 10 contractions, maybe 2 or 3 times a week, gave up because they didn't see any improvements. It's not a magic answer, like any muscle. It takes time and it takes practice. If you want to get a six-pack, it's not going to happen overnight. So it takes a lot of effort on the patient's part. So then I need to know, if you're leaking when you're running, it's not really appropriate to be doing all your exercises in lying. So we start in lying because it's the most easiest. You're not working against gravity, but then we need to move into sitting, standing, running, whatever's functional to the patient. So this is a face I see a lot when patients are trying to do their pelvic floor exercises. Everything's coming in, everything's scrunching up, they're using the eyebrows, they're using their facial muscles, and it's never really going to help your incontinence. So to strengthen your pelvic floor, you're really, again, thinking about those deeper muscles, from the pubic bone back to your tailbone. So everyone might like to try it now. We know that men have pelvic floors as well. So I'm just going to chat you through how I would chat my patient through a pelvic floor contraction. So again, using that breath, when you inhale, your pelvic floor and your diaphragm should come down ever so slightly. As you exhale, you want to close around your back passage like you're trying to stop wind. Then you're going to pull that contraction through to the front like you're going to stop urine. You'll gently feel your deep abdominals coming in as well, because they should work together to assist your pelvic floor. And then like any other muscle contraction, after you contract, you also have to let go. So I'm not going to get into it today, but a lot of my patients that I see maybe have pain with intercourse, chronic pelvic pain, and in that way we're getting moving more towards relaxing the pelvic floor rather than lifting it. So after every pelvic floor contraction, it's important that you lift, but also let go. There's a lot of people out there who are focused on thinking, I have incontinence, I need to strengthen my pelvic floor. They go home and squeeze, 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 squeeze. But a muscle that only works from here to here is never going to work as well as a muscle that works over its full range. So it's really important that we teach them properly. You have to lift that muscle, but you also got to let it go. So we're not just going in and say, squeeze your pelvic floor, okay, that's it, goodbye, go home. We do have an objective grading scale that we go through. I need to look at what their pelvic floor is, so like any muscle that's graded from 0 to 5. I'm looking for endurance, so how long they can hold that contraction, how many slow contractions they can do, how many fast contractions they can do. When they contract, are they actually elevating the levator hiatus, so are they getting a lift to their bladder and their bowel? Are they overusing every other muscle they can to get that contraction, or is it really isolated to their pelvic floor? And then what's their timing like? So can they contract their pelvic floor and cough without getting bladder and bowel descent? So these are all objective facts that I'm looking at that can then help guide a specific treatment program for that patient, going back to the NICE guidelines. That's what's going to be most effective. So it's shown that about 30% of women can't contract their pelvic floor at their initial consultation. And sometimes they see patients who are actually pushing down or bearing down, which again is going to be a lot more harmful than actually not doing anything at all. I tell my patients that really it is a training program. We're looking for overload, specificity, and also there is that element of reversibility. So it's not that you do these for 3 months and that's a magic answer. Like any exercise program, you do really need to stick with it for life, because if you give up on it, the muscle will revert back. So there's no real optimal protocol out there. That's why I think it's important that patients do have an individualized treatment protocol and what's realistic to them, because if I tell them to do 10 sets of exercises 3 times a day, if they have kids, if they have a busy lifestyle, if it's too overwhelming for them, it's just likely to fall by the wayside. So it's really chatting to your patient and finding out what's going to work for them. So from a management to treatment technique point of view, again, similar to what James mentioned, we're looking at those lifestyle changes and really training them through a bladder training program. Doing a bladder diary, so even instigating that in the GP practice is a really nice objective measure for your patients, because they can go away and say, oh really God, you know, I did go to the toilet 5 times after I had that 3 cups of coffee. Maybe there is something there. Maybe that is a simple change that I can instigate myself. Sometimes, again, if it's an overactive pelvic floor, there may be some manual therapy or soft tissue release that we need to do. And then where appropriate, we're using electrical stim biofeedback and discussing with our patients about incontinence products that can make their life more comfortable. So really for me, my whole interest is keeping women functional. So if it's your older lady who wants to get back to the gym maybe twice a week and do some weights, I'll give them some exercises incorporating your pelvic floor contraction with your upper limb weights, with a squat, with a lunge. Maybe it's a postnatal patient who, or pre or postnatal, who want to exercise even during their pregnancy. A lot of women that I see postnatally are struggling with kind of knowing what their new normal is and dealing with those changes in the pelvic floor. And I think, again, that's where we have a responsibility as healthcare practitioners to get in there early and support these women and keep women active and keep women healthy. So it's so important for our cardiovascular health and our bone health to be able to do these things. And a lot of the time, if women are leaking, they shy away from that, and that's something that really motivates me as a pelvic health physiotherapist to keep people healthy and keep people moving. From an evidence-based practice for lifestyle advice, there is evidence out there to suggest weight loss, smoking cessation and caffeine reduction can have a positive effect, but really we're waiting on better quality research to say that avoiding constipation, avoiding heavy lifting and avoiding heavy exercise can have an effect on prolapse and incontinence. So a question I always get asked is how come nobody told me this when I had children? And it always makes me a little bit upset. So if we lived in France, you're offered 6 women's health physiotherapy appointments after you have your children to help rehab your pelvic floor, to help you gain a normal sense of self, get back to intercourse without pain. And really I feel this is something that we should be asking women postnatally, how are they feeling, rather than how is the baby, and really having a look at their pelvic floor and seeing if there is issues in getting in there with early intervention. As I mentioned, a lot of my patients, it's a huge psychological impact. They'll say, I thought I was the only one, you feel so alone, it's hard to know who to turn to. But I think as public awareness and professional interest are increasing, we should hopefully get more support to these patients. It is a common disorder and it can be managed really effectively with simple interventions, first-line interventions such as pelvic floor physiotherapy. The NHS has recently come out with their Excellence in Continence Care mission statement. I'm nearly finished, but I'm just going to chat you through this. It says that physiotherapy has a vital role to play in continence care and needs to be considered as a part of any remodelling provision or workforce planning. Evidence has shown pelvic floor muscle training can be more effective than pharmaceutical management. Patients require specialist assessment to maximise conservative measures, and an MDT benefits from the expertise of nurses, physiotherapists and occupational therapists. So really again, just to draw it back to what I'd like to increase your awareness of, if you have any patients that come into you complaining of urgency or frequency that's affecting their quality of life, any leakage from the bladder in the bowel is not normal, a feeling of a vaginal bulge or something coming down, difficulty emptying their bladder in their bowel, postpartum rehabilitation, pelvic pain or pain with intercourse, they should really be referred to a specialist pelvic health physiotherapist. So we accept walk-in patients as well in the Blackrock clinic. They don't necessarily need a referral, but we always welcome a referral from a GP. So I'd like to thank you for your time. We don't want to get to this point. We don't want to realise that we should have done them. We want to be proactive and get in there from the start. So thank you very much.
diagnosed properly. The other thing about prolapse is if you take 20, 30 years ago, life expectancy was what, 65, so 65, 70. So patients were having vaginal hysterectomy and pelvic floor repair at the age of 50. They have 10, 15 years to live post-op, and they were most probably dying of some other medical condition. Now life expectancy is about 85, 90. So you do prolapse surgery at the age of 50, they have 30 years to live with. There's high risk of recurrence, highlighting the importance of post-operatively lifelong proper pelvic floor exercise. Yeah. And lifestyle modification, avoid heavy lifting, anything that, prolonged gardening, continuation, avoid putting on weight, continuation of pelvic floor exercise.
Yeah, I think that's a really good point, because a lot of my patients that I see, I blame gardening and grandchildren. So it's usually those two, that something went wrong with that. So I think that's getting them stronger. And then also I'll see a lot of patients post-op on the unit and then get them back for a reassessment. And I think it's that lifestyle adjustment to saying, okay, we don't want you to have to completely change your quality of life, but we want you to realize that you want this surgery to last for a long time. So getting these interventions in early really gets them on board, and thinking about contracting their pelvic floor when they're doing their gardening or when they're lifting their grandchild, and that's going to minimize and mitigate that risk of re-injury. Oh yeah, so yeah, so you were just wondering what the pelvic floor exercises were. So as I chatted you through, it's really using this group of muscles that is the deeper muscles of your pelvic floor. So they go from your pubic bone back to your tailbone and go out to your two sit bones. So really the best way to teach a patient how to contract their pelvic floor, you're looking for a close and a lift of these deeper muscles. So remember I had that slide with the face where everything is scrunching up. We really don't want that. It's just that deeper group of muscles. So what you want to think about doing is closing around the back passage like you were stopping wind. Then you're going to pull and lift that contraction through to the front like you were stopping urine. You might gently feel that your belly button tightens towards your backbone at the same time, and then you want to let it all go. So it's not a secret. I'm definitely open to sharing it. But it's usually something that people feel better going through one-on-one. Did you have a question?
I just had a question for James, please. Is there any estimate about when TVT surgery might be restarted, or what's your assessment? Thank you.
When we got notified to form an advisory committee, they hope to have this wrapped up at the end of August. We're now September. We still have to meet patient groups next month. I think the NHS will probably make their recommendation in early New Year, and we generally follow that, don't we, a couple of months later. But it's a concern. In the meantime, a lot of patients are maximising their physio. We're discussing alternatives with them, including our bulking agents, old-fashioned. I do have a patient that wants a rectus fascia sling, and that's fine. She's researched the article very, very well. I have elderly patients that probably wouldn't be fit for an operation, and a urethral bulking agent would be a better option. So, it is patient selected, but the answer, I suppose, to your original question, hopefully soon, but I would imagine towards the end of the year, early New Year. But I think once the recommendations are brought out, that we can get back on track with, I suppose, treating these women. One point I always make, Aoife touched on it there. Most of the patients that I see that have had an excellent outcome from TVT, a lot of them haven't told their friends, they haven't highlighted the issue. This was a very personal topic to them. One lady recently, a mother of 4, and she hadn't told anyone, and now she's back playing. But so it's something for us, and to highlight all of this is probably overall will hopefully be a good thing that we can get talking in the more public domain.
Okay, so we'll probably just go on to the next speaker. Dr. Kushal Juman is going to speak to us now about endometriosis, and we've a bit of good news. Professor David Gallagher will be able to join us, and so he and Owen will speak later. Thank you.
Thank you. Thank you.
Good morning. My name is Kushal Truman. I'm a consultant obstetrician gynecologist. Started in Blackrock about 8 months.
Just push it up his collar.
Yeah.
Not his tie.
My special interest is minimally invasive benign gynecology and advanced pelvic surgery, focusing on endometriosis, fibroid, prolapse. I tend to do most of my surgery either straight sticks or robotic. I would like to thank Blackrock Clinic as well for inviting me for the talk today. I think congratulations to James Ford, who recently became father to twins and still managed to give a fantastic talk this morning. So congratulations. It kind of reminds me of the first GP lecture that I gave. I got about 4 or 5 missed calls from my wife, and I managed to return a call at 6 o'clock in the afternoon, and I could hear her, sucking on Entonox, and she was like, "Where are you? My water's broke. I'm in labor ward. I've been trying to get hold of you for the past 2 hours." And then she said, "I know you have a very important talk to give to GPs. I'm not meant to be re-examined for a few hours. Go ahead, give your talk, and come back and join me." She's a midwife manager, so I trusted her. Went to give the talk. Needless to say, by the time I was presenting the last slide, the phone was ringing in the pocket. Had to wrap things up very quickly, leg it to the maternity hospital, and just managed to make it full birth. Thanks to the anesthetists who took some time to get the spinal anesthetic. But anyway, none of that stress for me. I had to. And I'm still married. She's now my secretary in Suite 9. Anyway, we're going to talk a little bit about endometriosis. Basically, endometriosis is the presence of endometrium outside the endometrial cavity. And the same way the endometrium responds to cyclical hormone, mainly estrogen, those endometriotic spots outside the endometrial cavity also respond to cyclical hormone. But when it's outside the endometrial cavity, this becomes an inflammation, giving respiration symptoms. Most of them endometriotic spots are found in the pelvis, mainly the urosacral ligaments, the pouch of Douglas, the ovary, the urovesical fold. But they can also be found on multiple other sites, such as the bowel, the bladder, the diaphragm, even all the way to the lungs. Endometriosis is categorized as superficial peritoneal, ovarian, or deeply infiltrating endometriosis. Most of the time, they are either superficial peritoneal or ovarian. Deep infiltrating endometriosis is only about 5% of all endometriotic cases. In terms of prevalence, it's very difficult for us to know exactly how many women suffer from endometriosis in the general population, because some patients will be asymptomatic, some patients will have mild symptoms that they'll put it down to just normal period cramps, some patients will have symptoms that might mimic sort of bowel or urological as opposed to endometriosis. But some studies that have looked at asymptomatic women, for example, patients having laparoscopic tubal ligation, identified about 1 to 7% of them having endometriosis. But if you do laparoscopy on patients with symptoms, for example, pelvic pain, about 70%, up to 70% will have endometriosis. If you do laparoscopy on patients who have fertility issues, up to about 50% have been reported to have endometriosis. In terms of prevalence, it peaks around the age of 25 to 35. We don't know what causes endometriosis. It's most likely to be multifactorial, i.e. a combination of presence of ectopic cells together with genetic factors or altered immunity or imbalanced cell proliferation. Where do those ectopic cells come from? There's a few theories out there. The most known one is Samson's theory of retrograde menstruation, i.e. when women have their menstrual period, some of the blood flows through the fallopian tube into the pelvis and carries some endometrial tissue that eventually gets deposited. Facts that support this theory is that women or girls with outflow obstruction or heavy period have a higher risk of endometriosis. Facts that don't support this theory is that, number one, 90% of women will have some extent of retrograde menstruation, but yet the incidence is not as high. The incidence of endometriosis is obviously not as high as 90%. Number two, it doesn't really explain how come endometriotic spots ends up in the lungs in extremely rare circumstances. So that brings on the lymphatic and vascular spread and also embryonic vestiges. The other thing that doesn't support retrograde menstruation is that endometriosis has been identified in young girls before the onset of menarche. In terms of risk factors, prolonged exposure to estrogen increases the risk of endometriosis. So early menarche, nulliparity, shorter menstrual cycle, also heavy menstrual flow. As I mentioned, outflow obstruction. There's genetic factors with family history of endometriosis, ethnicity being more common in Caucasians and Asians as compared to black female. And protective factors are multiparity, so pregnancy is protective, lactation, and late menarche. In terms of clinical presentation, as I mentioned earlier on, those endometriotic spots responds to cyclical hormone, but outside the endometrial cavity it becomes an inflammation, giving rise to their symptoms, i.e. dysmenorrhea, painful period. Typically, patients describe pain that starts a couple of days before the onset of their period, gets worse with the period before settling, and sometimes can extend before period is over. Dyspareunia, which is painful intercourse, mainly deep dyspareunia, so in the described as pain in the suprapubic or iliac fossa during intercourse. Most of the time due to endometriosis deposit along the uterosacral ligaments, because of the chronic inflammation and resolution, can give rise to adhesions, which can sort of make the uterus less mobile and can make the uterosacral ligament more rigid. Presence of chronic pelvic pain, endometrioma, either as detected on ultrasound scan as part of investigation for pelvic pain or picked up incidentally. Patients complaining of infertility, cyclical rectal bleeding, cyclical painful defecation, cyclical hematuria, anything cyclical, anything associated with onset of period, even described shoulder tip pain, cyclical shoulder tip pain due to endometriotic spots on the diaphragm. Always think of endometriosis and chronic fatigue. In terms of investigation, obviously abdominal examination and then your vaginal examination. And what you're looking for on vaginal examination is, number one, whether there's any adnexal masses that could indicate the presence of cyst or endometrioma. Number two is mobility of the uterus. And as I explained, the chronic inflammation and resolution can give rise to adhesions, can retrovert the uterus and cause the uterus to be quite fixed. And this is quite important for myself and other gynecologists when they're assessing patients, because it gives an indication of whether surgery could potentially be quite difficult or straightforward in a patient. And obviously, if the uterus is not very mobile, if it is quite fixed, if there is evidence of PR bleeding and all that, all those are indications that you could potentially be dealing with quite advanced endometriosis and therefore very difficult surgery. Nodules in the posterior fornix due to deep infiltrating endometriosis in the rectovaginal septum. Rare enough. Of 12 years that I've been doing gynecology, I've only seen 2 or 3 cases where I've felt it's like a cobblestone on the posterior fourchette, and when you do a speculum, it's like bluish deposits on the just behind the cervix. In terms of CA125, I don't see the relevance, certainly not in the premenopausal age group. It's a very non-specific blood test. As you know, it can be elevated in endometriosis, pelvic inflammatory disease. It can be elevated during normal menstruation. So random CA125 I tend not to do. If an ultrasound scan shows endometrioma with characteristic features of homogeneous low echogenicity cystic mass on the ovary, I don't see any need to do CA125. The only time that I do CA125 is in postmenopausal age group if there's mention of complex suspicious cyst, or indeed complex ovarian cyst suspicious for neoplasm. In terms of imaging, obviously ultrasound scan is the cheapest, most accessible first-line investigation, and it's mainly to look for endometrioma for investigation of pelvic pain. In right hands, it can also pick up nodules, but deep infiltrating endometriosis and adhesions, possibly MRI might be a better image modality, but always start with ultrasound scan first. In terms of diagnosis, we can always make a presumptive diagnosis, and that's most probably relevant to you. We don't need to get a definitive diagnosis of endometriosis. You can make a presumptive diagnosis based on patient symptoms that I've mentioned early on, based on ultrasound scan findings. And you can initiate treatment based on a presumptive diagnosis, treatment of which I will discuss later on. But if you want a definitive diagnosis, laparoscopy is the gold standard. And what you're looking for at laparoscopy is you're looking for raised flame-like lesion, white opacification, adhesions, endometriomas, powder burn lesions. And based on what you see at laparoscopy, you can stage the endometriosis from stage 1, which is only some superficial deposit, all the way to stage 4, which is severe, thicker deposits with association of endometriomas and adhesions. The relevance of staging, the problem about staging is it doesn't correlate with the patient's symptoms. So I've seen patients with stage 1 endometriosis that are crippled with pain, but I've seen patients with stage 4 endometriosis who didn't have a clue that they had endometriosis. The relevance of staging is that if I'm getting communication from a consultant gynecologist saying that this patient has stage 4 endometriosis, needs a hysterectomy, at least I know what I'm dealing with. And I'm unlikely to go straight for hysterectomy in that patient without doing a look in laparoscopy by myself first, possibly together with a colorectal surgeon. Whereas if the same referral with a stage 1 endometriosis, you possibly know what kind of pelvis you're dealing with, and that, if they need a hysterectomy, is most likely to be straightforward. The other thing to mention about the staging is that stage 4 endometriosis is more likely associated with fertility issues, most likely due to anatomical distortion. And also the inflammatory process of endometriosis causes release of cytokines and other inflammatory markers that makes implantation and pregnancy a little bit hostile, therefore contributing to infertility. This is what it looks like in real life. This laparoscopy I did about a year and a half ago. You can see, you can see bilateral endometrioma. This is the uterus, bilateral endometrioma with the right side completely pulled centrally, stuck on the pouch of Douglas, the sigmoid colon completely adherent to the left pelvic side wall. And you can see a little bit of brown deposits here, which is endometriosis, and also sort of obliterated patch of Douglas. And again, brown spot of endometriosis just behind the left ovary, brown spot of endometriosis. In terms of management, the aim to manage endometriosis is to try to manage the symptoms medically for as long as possible and leave surgery when you don't have much option. And the reason for that is to prevent multiple repeat laparoscopies on women during their reproductive period. And that's certainly supported by the American Society of Reproductive Medicine. And surgery or management indeed will depend on the patient's age, the severity of their symptoms, what you find clinically, what you find on imaging, and their fertility wishes. And your options are conservative, medical, or surgical, same as any medical condition. Conservative, what I mean by that is, for example, someone has an ultrasound scan, they pick up a 3 or 4 centimeter endometrioma, she's relatively asymptomatic, you don't have to dive in and do any sort of surgery or start any treatment. You can monitor the cyst. Endometrioma are unlikely to resolve spontaneously and are unlikely to resolve with medical treatment. Medical treatment, we are talking about non-hormonal or hormonal medication, and all those can be initiated by you based on presumptive diagnosis. So non-hormonal medication, I'm talking about anti-inflammatories, Ponstan, diaphene, ibuprofen. Hormonal medication, I'm talking about combined oral contraceptive pills, progesterone-only pills, Mirena coil, depot injection, and decapeptyl. My first line of treatment, ideally, I like starting patients who don't have any contraindication to combine oral contraceptive pill, start them on cyclical COCP. I tend to use Yasmin or Clara, start them cyclically first together with a non-steroidal anti-inflammatory like Ponstan or Difen or Ibuprofen, and then reassess in 3 to 4 months' time. If they have some response but not to their satisfaction, you could put them on the same COCP back to back. 3 months, 1 week off, 3 months, 1 week off. So their symptoms happen 4 times a year instead of 12 times a year. And there's no harm doing that. If they have contraindication to combine pill, for example, smokers above the age of 35, high BMI, no problem starting on progesterone-only pill. And my preferred one, the only one I use is Cerazette. And even if they've tried the combined pill before, have had some result but not significant enough, you can always try them on the mini pill. And there's no evidence that one works better than the other, that one type of combined pill works better than the other. It's what's available, so a little bit sometimes can be a little bit of a trial and error to find the right combined pill that brings the best benefit, keeping the side effects to the minimum. Mirena Coil, Depot, and Decapeptyl, all those are options. Decapeptyl, I tend to leave them for a few situations. Number one is, let's say, high-risk surgery, stage 4 endometriosis, significant risk to bowel and bladder, and you know, after a consultation, patients don't want surgery, so you can give them Decapeptyl, especially when they are very close to 50s or close to approaching their menopause. You only need treatment for a few years, and once they go through the change, symptoms of endometriosis tends to settle. And there's no problem giving Decapeptyl long-term, even more than 6 months, even a year, as long as you add back HRT, and I tend to add back Livial to keep their menopausal symptoms under control. The other time that I give Decapeptyl as well is if there's any need for surgery, give it for a couple of months before just to calm all the inflammation in an attempt to make surgery a little bit easier or less difficult. Surgery then, obviously based on patient symptoms, if there's no response to medical treatment, presence of endometrioma, obviously if they are trying to conceive, your hormonal option, your hormonal medication option is not an option anymore. So you have a lower threshold to operate on those patients. And the type of surgery obviously depends on what you see, but your options there is to ablate those endometriotic spots, excise those endometriotic spots. If there's adhesions, to try to free up the adhesions. If there's cysts, to remove the cyst and preserve the ovary. Those are conservative surgical management. Definitive surgical management, you're talking about bilateral sapping oophorectomy only. And the only time you will do that is if there's adhesions to the uterus, whereby doing hysterectomy would increase the morbidity associated with surgery. For example, patients with multiple cesarean section, patients with bowel stuck to the back of the uterus or the uterosacral ligament. So you just do a BSO and keep morbidity or risk of surgery to a minimum. Hysterectomy only without the removal of ovaries has been shown to relieve pain associated with endometriosis and to relieve dysmenorrhea. Even though I've said that endometriosis responds to estrogen, so leaving the ovaries behind will still release estrogen as long as there's no spots of endometriosis around the pelvis or at the time of hysterectomy to ablate those endometriotic spots. But you will do that for patients that's in their early 40s, whereby removing the ovaries will put them through surgical menopause, which also on the long term has medical implication. And obviously the most definitive surgery would be removal of the womb together with the ovaries. So again, going back to that picture, this was a 45-year-old woman who was referred to me from a colleague of mine who did a laparoscopy on these patients because of dysmenorrhea, and she drained the endometrioma. Drainage of endometrioma, unfortunately, doesn't work too well because there's a high risk of reaccumulation. But refer the patient to me to consider hysterectomy. And certainly at consultation, the patient was very keen to proceed with hysterectomy. And at the time, I didn't have any picture of the pelvis, but based on the description, I knew I was dealing with a stage 4 endometriosis. And two things happened. Number one, when I went through her history, I realized that she hadn't tried Cerazette, as part of her medication. And number two, when I went through the risk of bowel surgery and risk of having bowel injury and bowel resection and stoma, obviously, you know, to try to bring her from 45 to 52 to gain about 6 years, you know, obviously they kind of take this bit of information and go home and reconsider the whole aspect of surgery. And she agreed to try Cerazette. So I put on Cerazette and reviewed her about 3 months later. She had very good response to Cerazette. So she continued on that. At the time when she came back after 3 months, she had a little bit of discomfort in the abdomen, so I got her pelvic ultrasound scan in the meantime. So when she came back, she had ultrasound scan showing bilateral endometrioma. Her symptoms, unfortunately, had recurred. And sometimes it does happen that a treatment works for a period of time and then they start getting symptoms again. The first 2 months, if they start getting symptoms again, there's no need to suddenly change their treatment. Try to encourage them to continue on the treatment that initially worked. There's a possibility that it might settle again. But if you've encouraged for 2-3 months, the symptoms still then getting worse, yes, we need to alter their treatment regime again. And she was also complaining of new onset of heavy period. So there was a few reasons for me to laparoscope this patient. Number one, presence of bilateral endometrioma. Number two, worsening of symptoms. Number three, heavy period. And it also gave me an opportunity to personally assess the pelvis and see if I was to do laparoscopic hysterectomy on this patient in the future, what am I dealing with? And this is what I saw, exactly like I described early on. And there was a little bit of endometrial tissue, ovarian tissue on the left ovary, but the right ovary was completely gone. I couldn't identify any ovarian tissue there. So what I did was to mobilize the right endometrioma completely from the pouch of Douglas, and I took out the right ovary and endometrioma, and I did a cystectomy on the left side. The reason I didn't do a left salpingo-oophorectomy is because the bowel was coming quite close. So to remove that would have exposed that patient to risk of bowel surgery. And that's what it looks like at the end. So right endometrioma completely gone, pouch of Douglas freed up, cyst gone on the left ovary. So about 6 weeks after, first time she came in, 6 weeks after, no significant improvement to her symptoms, which I was a little bit surprised. The other thing that I didn't mention, I also put a Mirena coil in this patient. Important because after surgery, you also have to manage this patient's symptoms for as long as possible medically so that you don't have a recurrence and having to laparoscope this patient again. So the Mirena coil was inserted to try to keep the endometriosis at bay, but also control the heavy period. So 6 weeks, not much improvement. Encouraged her to keep the Mirena coil in, gave her some Ponston, reviewed her 3 months afterwards, and thankfully there was a significant improvement in her quality of life. Things that she would describe is, for example, instead of missing work for 5 days during her period, now she can go to work and possibly miss 1 day because of pain. She can resume sexual activity. And that brings an important point, is to manage patient expectation. I never tell them that I will get rid of all their symptoms. I never tell them that, after surgery, after medication, that they will have a, pain-free. Those patients, it's a chronic condition. Those patients have chronic pain. What I tell them is that I'm going to try my best to improve their quality of life. And that's what you're trying to get, is that if they give you 50% reduction in their symptoms, if they tell you that, you know what, I'm happy with how things are at the moment, I'm happy, I'm able to have a sexual life, I'm able to go to work, I'm able to function day to day, but 1 or 2 days is bad, that's a result. It's sometimes very difficult to get rid of the pain completely in those cases. Other things that I've seen more and more is acupuncture, diet control, omega-3, exercise. If patients find that helpful, if it's improving their quality of life, if it gives them a good, feeling factor, by all means, encourage it. Thank you very much.
Thank you. Can I ask you about hormonal control of symptoms? I thought that the hormones worked by stopping you producing blood, which caused retrograde endometriosis and pain. But if you have a Mirena in, it'll only stop the blood coming from the womb, and you still have all those spots of bleeding outside the womb. So how does it help? And similarly, how does Cerazette help?
What they do is they cause desidualization of the endometriotic spots. Basically, what happens is it's not that every time you have a period, the endometrium flows outside the womb and causes symptoms. This happens over time. That's a theory, is that over time it carries the endometrium and some gets deposited on and gets embedded in the peritoneum, and over time those spots that most probably got deposited a couple of years ago start reacting to estrogen. So what the combined pill, the mini pill, and Mirena coil does, it causes desidualization of those spots that has been embedded in the peritoneum for whatever number of months or years, and it causes atrophy of these endometriotic spots in the peritoneum, therefore preventing them from getting active. It's not trying to stop a period that causes resolution of the endometriosis symptoms. Is trying to make those endometriotic spots that are already deposited in this patient's pelvis inactive. That's why you're trying to do.
Okay, so the Cerazette doesn't need to cause amenorrhea in order to work?
No,
okay.
It's trying to cause desidualization and atrophy of the already deposited endometriotic spots in the peritoneal cavity.
Thank you.
What acupuncture points would you use?
I'm not sure, to be honest. They come in and they say, I've had acupuncture for the past 3 months, fantastic. I'm like, perfect, go for it. You know, I'm unsure, I'm sorry about this.
Sorry, you'd mentioned oral contraceptives, Depo and Mirena. Is there any role for Implanon? Would that act in the same way, or?
I don't think Implanon, I haven't had good results from Implanon. The only use I see of Implanon is a contraception use. I don't tend to encourage that for treatment of endometriosis. I'm also not a fan of Depo, even though I've seen 1 or 2 patients having good response from Depo, and surprisingly not with Mirena coil and not with the combined pill. But I wouldn't include Implanon as a treatment of endometriosis. I'll leave that to contraception only.
And then similarly, the efficacy rates between Mirena and oral contraceptives and Depo, is there a huge discrepancy? Obviously, combined oral contraceptive would be first line, but in patients that have contraindications, would the Mirena and that be similar, or is there much of a difference?
In terms of contraceptive, or in terms of treating endometriosis?
In managing endometriosis, is there much of a difference?
You're comparing combined pill and Mirena coil and the mini pill. Yeah. My first one would be combined pill. It's funny because different combined pill tends to bring different result to patients, and different patients will respond to combined pill and not with the mini pill. And I get the other way around as well. And I don't know why. I've seen patients who have tried the combined pill, like this patient here. She has tried the combined pill before and didn't get much response, but she did get a good 3 to 4 months response from Cerazette. I don't know why. In terms of choosing between the mini pill and the Mirena coil, it's same pros and cons. The good thing about the Mirena coil is once it's in, it stays in for 5 years, so you don't have to think about taking a tablet every day. If the patient has another problem of, let's say, heavy period, irregular cycle, possibly Mirena coil might fit better than Cerazette because it's going to control the cycle better and also manage the endometriosis symptoms. I'm a fan of the Mirena coil, I have to say.
Hi, Kushal. Just wondering, with the new Kylena, would that be as effective as the Mirena?
I am unsure. I'm not familiar. Sorry.
Sorry, just asking, between patient who's had treatment for their endometriosis surgically and now having IVF, in between their IVF trials, should they be on something to control their endometriosis?
So they are in between the IVF. Unfortunately, the issue with patients with endometriosis and trying to conceive, whether naturally or IVF, is that you're limited in terms of what you can give them. So the whole hormonal option is gone, like a decapeptyl, combined pill, the mini pill, all that is gone. So you're really looking at only sort of anti-inflammatory medication to control their pain, or surgery.
Okay, and this person's had both of their endometriomas removed, so they have no chance of, conceiving naturally. So it would be there's no benefit really from them being on the pill or anything like that.
This person has had multiple endometriomas, so she's going for IVF, yeah?
Yeah, exactly. So she can't conceive naturally.
Yeah. So again, I would say the hormone that they will have to give this patient to sort of retrieve the egg won't do any favor to the endometriosis. At the same time, we can't give anything to sort of suppress the estrogen or suppress the ovary, because we still need the ovary in the process of going through IVF.
Okay, perfect. Thanks.
Thank you very much, Dr. Truman. So now we're going to have Professor David Gallagher and Mr. Owen Haney going to speak to us about a topic we're having more and more questions in as general practitioners about screening, who's appropriate to screen for genetic cancers, and how this affects their care. Thank you very much.
Thank you. You'll have to forgive me if this is a bit subdued. I had a visit from a vomiting bug overnight. So I'm going to talk for you about 10 minutes or so, and I guess discuss points that I think are important in genetics. And then my colleague Owen Haney is going to take over, and he's a full-time genetic counsellor who's recently returned from the UK and employed in Blackrock Clinic. So when we talk about genetics, we talk broadly about two areas: somatic and germline genetics. The first, somatic, refers to tumour genetics, which is what, as a medical oncologist, what I spend half my time focusing on. The second, hereditary or germline genetics, focuses on our core genetics, and this, as a geneticist, is what I spend my time on and what Owen focuses on. It's increasingly somewhat artificial to separate these in caring for cancer patients, because when we test the DNA of a tumour, we're testing both the somatic DNA, the changes that have occurred within the tumour, and the germline DNA, the DNA that we inherited from our parents and that we carry in every cell in our body. So I'm going to tell you a story of a missed opportunity. This is a young woman I look after in my medical oncology clinic. She's a 36-year-old mother of 3. She noticed a breast lump while breastfeeding her 5-week-old. She had a biopsy of this breast lump, and as we always do when we're biopsying breast lumps, we looked for 3 proteins on the surface, and she carried all 3. So she had what was known as a triple positive breast cancer. She had a PET scan, which unfortunately showed multiple small FDG-avid liver lesions, and then she had an MRI scan of her liver, which confirmed these to be multiple liver metastases. Now, because she has a HER2 positive breast cancer, she initially went on chemotherapy with docetaxel and 2 antibodies, Herceptin and a second generation Herceptin pertuzumab. She has since stopped the chemotherapy and is just on the 2 antibodies and living an effectively normal life. However, and this is pretty much as good as medical oncology can do, both Herceptin and pertuzumab represent 2 of the best advances we've had in caring for cancer patients. But even with that, she'll be dead in 4 years. The tragedy of this case, I don't know if I have a pointer on this. I do. So this is the woman. Where is she? Oh, I went on one today. Okay. Here she is. So we had met her we had met her mother in clinic previously, or sorry, her aunt in clinic previously, and found her to have a BRCA2 mutation. And when we find a BRCA2 gene, or any gene in a person, we give an information leaflet to that individual and ask them to disperse it among their family members. And her aunt had done. She'd given it to this woman and her 2 sisters. Her 2 sisters had taken up genetic testing and didn't carry the gene. She was in the midst of starting a young family and raising a young family, and figured she'd get around to it when she could, and she never tested. So unfortunately, she missed her opportunity to prevent her either getting this cancer or have it diagnosed at a very early stage. This is another case. This is the proband in the family, 64-year-old woman with ovarian cancer. We've again found a BRCA2 gene in her. This woman is currently my patient with metastatic triple-negative breast cancer. Again, we gave an information leaflet to this woman, asked her to disperse it among her family members. She did. She didn't know these people, but she knew the brother, one of these brothers here, and she gave it to him, and he tossed it in the bin. He didn't think it was relevant. And his sister has just been diagnosed with metastatic breast cancer. And there is another case in the family. Over here, a stage 3 ovarian cancer, again, could have been prevented. Similar to the first story, she was given the results, but elected not to act on it. I guess the relevance of that for this audience is a lot of the time we disperse these things and then they come into their GPs looking for information on how important is it to have this done. And sometimes they are reassured incorrectly that they have time to wait, or another point I'll come to about discrimination in insurance. So the brother that tossed the thing in the bin, a lot of people think these genes are just relevant for women. They're not. The one group that prostate cancer screening definitely works for is the BRCA gene carriers, the male BRCA gene carriers. This is a study that showed that we participated in with the Royal Marsden, showing that PSA screening from 40 years of age saves lives. I have 2 men dying under my care in their late 40s with metastatic prostate cancer. Similar stories, could have had prevention initiated, but didn't. And this is a Swedish family registry study. The red circle's a little bit off here, but this is prostate cancer here, showing that it's the most heritable of all cancer. 42% of prostate cancer is directly attributable to genes that people carry. This is another case, 67-year-old man was diagnosed with metastatic colorectal cancer to his liver. So when we diagnose colorectal cancer now, we often do a protein test looking for what are called mismatch repair proteins for 2 reasons. One, to try and diagnose Lynch syndrome, a hereditary predisposition to colorectal cancer, which Owen's going to talk to you a little bit about. And secondly, to identify tumours that may be amenable to treatment with immune therapy. But about 5% of the time, the testing of the proteins is expressed, and it's a false positive result. So this man had a liver resection, he recurred, he then had every systemic chemotherapy that we have for metastatic colorectal cancer, and he ultimately died in December of last year. But just before he died, we did a somatic test, so not like the germline test that I've been talking about, the tumour test. And we found a change in his tumour DNA in a gene called MSH6, which is a Lynch syndrome causing gene. We got this result back actually when the man was in the hospice, and one of my nurses went over to the hospice and drew blood from him, and we found that he did have a hereditary gene also that predisposed him to cancer in this mutation in this MSH6 gene. The power of that is that we've now been able to test his 5 kids for that gene and find out that 3 of them carry it, 2 of them don't, and they've now started colorectal cancer screening from 25 years of age in the ones that carry the gene. This is another case of Lynch syndrome. This is a 27-year-old man I look after. He was diagnosed with a rectal cancer. He had what we typically do in rectal cancer. He had neoadjuvant chemoradiation, which is chemoradiation before the surgery. Then he had a surgery. He then came to me for his post-operative chemotherapy. And when he was starting it, he had some lower pelvic and back pain, which is not that unusual in someone post an APR for a rectal tumor. But the pain got worse, so we did an MRI, and he had a metastasis in his lower spine. And he went on chemotherapy. He had a horrid time on chemotherapy. He was an inpatient, he lost a ton of weight. He developed what's called a 5FU colitis, where he was just pouring out fluid per rectum. He was on continuous IV hydration, on TPN. He was an inpatient for about 4 weeks in the hospital. We then did genetic testing on him, and we found that he had an MSH6 variant that had never been found anywhere else in the world. And we've since worked that up, and he too has Lynch syndrome, which has relevance for his family members, and they've now tested, and we found that his mother has Lynch syndrome too, and she's screening, and one of his siblings also has it. But the huge relevance for this man is that he is eligible for immune therapy. So immune therapy works very well in Lynch syndrome associated cancers. The challenge we have in Ireland right now is immune therapy is not reimbursed in the public or the private setting. So I met this man in St. James's Hospital on a Friday. You have somewhat of an ethical dilemma as to whether you tell this person about a drug that could potentially work very, very well, but is not reimbursed, and we've no way of getting it other than us applying directly to the pharmaceutical companies and him purchasing it. So I told him about it on a Friday afternoon. He's from Tala. He went back home with his parents. He came back to me on a Monday morning and said that his boxing club have raised 50,000 euros to purchase this drug. So that's what they did. He's now 3 months on. He's now about 5 months on. He initially had what's called a partial response, which means that his tumor had reduced by greater than 30%. His had reduced by greater than 70%, and it's now gone on this drug. He's back living his life, back working, and bear in mind that when he was on traditional chemotherapy, he was an inpatient on total parenteral nutrition. So this is the power of genetic testing, both from a preventive perspective and from a therapeutic perspective now for cancer patients. We have probably the worst staffed genetic services in Europe. I run the national service on 1/3 of my contract in James's. I have 2 genetic counsellors and 3 nurses who work with me there. 2 colleagues share a post in Crumlin. And we now have services in the private, which is adding very meaningfully to the access to this treatment nationally. The way we do it is patients come to Dublin from around the country. We take their blood and send it to the UK. We still don't have a molecular genetics lab in Ireland. And we then get the results back and meet with the patients and talk to them predominantly about prevention, but increasingly about therapeutic relevance of genetic testing too. This is an old slide now. This is really there to give you an idea as to how the demand is increasing for genetic testing. This is my clinic in James's. In 2016, it went up to 1,250 new referrals. I can tell you the line has continued to grow along the same curve. One really important point I want to make, and I hear it every week in clinic, is that it is illegal in Ireland for individuals to be discriminated against based on genetic testing. So you can't be refused mortgages, you can't be refused health insurance policies. It's a message that is slow to get out, but we passed an act. We were one of the first countries in Europe to pass an act in 2005 to make genetic discrimination illegal. Up until this year, we didn't have a legislature covering this area. There's quite a well-developed one in the United States, but over the summer we had the first case of a woman who sued her gynecologist for not testing or not referring her for genetic testing. It was settled out of court, but I think what this illustrates is the increasing awareness that patients and families have of the importance and power of genetic testing. So I hope I've convinced you that an ounce of prevention is worth a pound of cure. I firmly believe that prevention could be particularly powerful in a small country like ours. There is no reason why we can't identify every BRCA carrier, every Lynch syndrome carrier in Ireland, and prevent them getting and dying from cancer. Men matter too. They carry the gene 50% of the time. They get breast cancer. I have 2 patients currently dying of metastatic breast cancer who are male BRCA carriers. They get prostate cancer. They get a more aggressive type of prostate cancer than non-BRCA carriers. Discrimination based on genetics grounds is illegal in Ireland. Through the National Cancer Control Programme and the NCCP, we are actively trying to develop a funding and infrastructure to broaden this out in tertiary care and ultimately, hopefully, in primary care. And I'd like to applaud the Blackrock Clinic for investing in this and for convincing Owen to come home, because access to testing has been a real issue in our country, and it's one of the few areas where private health care hasn't contributed to, and I'm delighted that it is now. Thank you.
Thanks, David. Hi, everybody. Just to introduce myself, my name's Owen Hanney, and I'm what's called a genetic counsellor. My background is I did an undergraduate degree in genetics in Trinity College in Dublin, and then I did my master's degree in Cardiff University, and that was like a 2 years vocational master's to train to become a genetic counsellor. As David mentioned, I've been working in the NHS in Dundee for the last 4.5 years, and recently came home to help set up the cancer genetics clinic here in Blackrock Clinic. A question that I get asked quite often is, what is genetic counselling, or what do you do? And I still find it hard to kind of explain that. I'll do my best as we go along. What I'll do today is tell you a little bit about the role of the genetic counsellor in all of this, give you a few pointers about which patients we actually want to see in clinic, and then tell you a little bit more about the service. So, the definition of genetic counselling, so this is a bit wordy, is it's a communication process which aims to help individuals, couples, and families understand and adapt to the medical, psychological, familial, and reproductive implications of the genetic contribution to specific health conditions. So yeah, it's quite a mouthful. But I suppose what we focus on as much as, I think David in his kind of talk there was saying, well, you know, what information can we do? What can we do to prevent particularly cancer in families? I suppose my role is to kind of talk about more probably the psychological impacts as well as the medical impacts of having a genetic test. So I'm going to use this diagram to try my best to explain it. When you refer a patient into the genetics clinic, the first thing that happens is they get an appointment with the genetic counsellor or the genetic nurse. The first aspect of our job is to take a very detailed personal and family history from the patient, and then try to interpret from that family history, is there a possibility of there's something genetic in the family, particularly I suppose in this case in the cancer clinic, is there the chance, does it look like there's a faulty gene causing a high risk of cancer in the family? So the first step is always a risk assessment. Now, a lot of patients that come through our doors, we might take their family history of cancer, and actually the pattern that we see, or the cancers that we see, or the ages of diagnosis don't really fit with the likelihood of there being a cancer predisposition, and therefore we can give the patients peace of mind. For other families, there might be quite a strong pattern of whether it be breast cancer or bowel cancer in a family, and we're suspicious that it might be something genetic. So it's our job to say, well, what genes should we be looking at, and what are the implications for the patient and their family if we test for these genes? So that's where the second kind of role of education comes in. It's probably one of the most important roles of the genetic counsellor is to provide the patients and their families with accurate information about what it means for them if they have a genetic test and what the results might mean for them and their family. Genetics is quite complex, so a big part of the role is trying to break down that complex scientific information so it's easier for patients to understand. Another important thing is that patients are totally informed and giving you informed consent if they're proceeding to have a genetic test, because it can have huge implications for them. I suppose that kind of leads on to where the counselling aspect of genetic counselling comes in, is that deciding to have a genetic test, particularly for cancer genetics, can be probably one of the most important decisions someone will ever make. I'm going to kind of give you a couple of examples of the patients that we see to explain this. Many of the patients we see in clinic will either be suffering from cancer or will have had cancer previously. Choosing to have a genetic test, and if we find, say, a fault in BRCA1 in a patient like that, it actually could mean for that patient that they have a very high risk of developing a further cancer in the future. So taking that on board for patients actually can be quite difficult, and actually facing the fear that they might get cancer again. If you turn it around the other way, if we establish that there's a mutation causing an increased risk of cancer in a family, let's say again BRCA1, and we get what we call an unaffected family member comes in. So someone's mother has had breast cancer, she's found to have a BRCA1 mutation, and her daughter comes in to get tested. There's a huge lot of psychological implications as well as medical implications for that patient if she decides to have testing. She's seen a very close family member go through cancer treatment, and now I'm doing a test with her that could tell her that she has a very high risk of having the same type of cancer. So for a lot of people, that's an awful lot to take on board. So I suppose genetic counselling gives patients the space to talk about all these different issues that can crop up. The other thing that's a little bit different about genetics is a test doesn't just have an implication for one person in the family. It can have implications for the whole family. So if we identify a faulty gene in one person, it means that their siblings will have a 50% risk of the same thing. Their kids will have a 50% risk of the same thing. And on one hand, that can be quite scary for patients. But on the other, if we can clarify what those risks are, who has those risks, we can put plans in place in regards to screening and cancer prevention and surgical interventions to prevent cancer from happening in the first place in these families. And then the support aspect comes with, I suppose, just supporting the families through that whole process. Generally, we have half an hour to 45-minute appointments with patients. If something's kind of quite complicated or the patient needs time, we'll encourage them to take some time and come back and see me again to go through it in more detail. So just to recap very simply what happens in a genetic counselling appointment, the first section is a risk assessment. So if you are referring patients to us, I suppose the idea is that they're not presuming that they're going to have a genetic test. Not everybody that walks in the door will be eligible or will need a genetic test. We may end up giving them advice about screening, but they might not need a genetic test. I suppose we'd like your help a little bit with this as well, because the more detailed information you can put on a referral letter coming into us about the patient and their family, the easier it is for us to make a risk assessment and give them the right advice. If someone is affected by cancer and there's a strong family history, we'll do what's called a diagnostic test. So this is where we're trying to find what's causing the problem in the family. We don't always find what's causing the problem in the family. There's plenty of families out there where there's lots of cases of breast cancer or lots of cases of bowel cancer, and we can't put our finger on what's causing the problem. We will still give family members advice about what they can be doing to keep themselves safe. And the other type of testing is that scenario I talked about where we know there's a faulty gene in the family and other people in the family are coming to have a test. And again, sometimes genetic counselling is nearly more important in that group because there's a lot more worries and things to think about for women deciding to have a predictive test. Again, if we go back to BRCA1 and BRCA2, if a woman in her 20s is coming to have a test like this, if she's found to have a BRCA1 mutation, she needs to think about when does she start her breast screening? Does she consider having risk-reducing breast surgery to have her breasts removed? When is the right time for her to think about doing that? If it is the right thing, she'll need risk-reducing ovarian surgery at some stage in her life. When she'd be thinking about that? And we can go through all of that with women in those appointments that they know what they're kind of getting themselves into, are fully informed when they're making those decisions. So I'm going to do a little whistle-stop tour on hereditary breast and ovarian cancer and Lynch syndrome. What I'd really encourage you to do is go away and look at a couple of things when you go home. One is on the Royal Marsden website. There's a really good piece of literature called A Beginner's Guide to BRCA1 and BRCA2. I encourage all of my patients who are undergoing testing to read through that. It's the best resource I've come across. It's very detailed, and it talks about both the cancer risks, but also the screening, the surgical implications, and also the psychological implications of having a test for BRCA1 or BRCA2. Again, another thing I'd encourage you to read if you have the time is in 2013, Angelina Jolie did an op-ed piece in the Time magazine discussing the fact that she has had genetic testing and has been found to have a BRCA1 mutation. Her mother passed away of ovarian cancer in her early 50s, and I think her maternal grandmother had breast cancer. That encouraged her to seek genetic testing. She was found to have a BRCA1 mutation. She has since had risk-reducing double mastectomy and reconstruction, and she has had risk-reducing bilateral salpingo-oophorectomy. The piece is quite good. It gives her opinion. The only thing I'd say is that her opinion wouldn't be the same as all women's opinions in that situation, but she was very much so taking preventative risk-reducing surgery measures, gave her peace of mind and gave her control over her risk. And it's something that she had been worried about quite significantly for large portions of her life. This is pinched from the Marsden Guide, and it talks about the risks associated with BRCA1 and BRCA2. Now, what I would say is that the risks on this are probably a little bit overestimated, but are good ballpark figures. When we're talking about BRCA1 and BRCA2, the lifetime risk of developing breast cancer for a woman might be as high as about 80%. For women with BRCA1 and BRCA2, again, depending slightly on the gene, your risk of developing ovarian cancer, again, is quite high. It can be between about 20 to 40%. And again, the risks differ slightly between the two. As David had mentioned earlier on as well, there's an increased risk of male breast cancer and prostate cancer for men, particularly with BRCA2. But again, something we see in genetics quite a lot is that men think it's not important for them to have a test. That's something that the women need to worry about. Well, first of all, there's the prostate cancer risk and the breast cancer risk. And second of all, if those men either have daughters or go on to have daughters in the future, it's very important for the men to know if they have the faulty gene, because they can have it and pass it on. It might not cause them any problems, but it may be important for their children to know in the future. I suppose something to reflect on as well is that in the genetics clinic, David was showing you kind of the family trees that we draw. We try not to look at just the patient. We can give advice to say, these people in the family also need to know and come and see us and talk to us about this. So some take-home messages for you guys, things to be suspicious of or look out for. So first of all would be the number of breast cancer and ovarian cancer cases in the family. I suppose particularly if you see both breast and ovarian cancer, that's suspicious. You'd want to be referring them to genetics to investigate that further. The ages of the cancer diagnosis. So if you see women who've been diagnosed with breast cancer or ovarian cancer, or I suppose men with prostate cancer at younger ages than you would be used to seeing, that is an indication that there might be something genetic going on. So if there's women in their 20s, 30s being diagnosed with ovarian cancer, or women in or with breast cancer, or women in their 30s or 40s with ovarian cancer, be thinking, could this be something genetic? The number of generations that you see cases of cancer in a family as well. Does it look like it's moving down through the family? Although that's not always apparent. Are there any cases of bilateral breast cancer or women who've both had both breast and ovarian cancer? Again, that's highly suspicious that we might be dealing with a BRCA1 or BRCA2 mutation. Male breast cancer, as David had mentioned. Prostate cancer, particularly young prostate cancer. And tumor type. There's a specific type of breast cancer called triple-negative breast cancer that you tend to see slightly more commonly in women who have a BRCA1 mutation. Now, that's not to say that every woman with triple-negative breast cancer has a BRCA1 mutation, but we see more of that group of women are BRCA1 carriers, and they would be eligible for testing and should have further investigation. So, who to refer? Young breast cancers, women with young breast cancer, bilateral breast cancer, who've had breast and ovarian cancer, triple-negative breast cancer, have a very strong family history, or there's a family history of male breast cancer with all of that. Well, I should say that we've got leaflets printed up for you to take home that kind of go back over the who to refer slides. So I'm going to whiz through them, and you can have those to take with you and have a look at. And again, if you have any questions about your families, you can always drop me an email or a phone call and say, listen, a woman came in to me and told me about this family history of cancer. I'm happy to give you advice about whether or not they need to be seen. So I'll whiz through this a little bit. Pretty much what we know now is that between about 10 to 15% of all epithelial ovarian cancer is probably down to BRCA1 or BRCA2. So we've got quite a low threshold for testing women with ovarian cancer at the moment. So anybody with a high-grade serous ovarian cancer should really be sent to genetics at some point depending on where they are with their treatment. The other thing with ovarian cancer is actually testing for BRCA1 and BRCA2 can actually help direct treatment as well, because they're PARP inhibitors that work particularly well in women who do have a BRCA1 or 2 mutation. And again, that's something that will be coming in the future. Very, very briefly, Lynch syndrome is associated with primarily an increased risk of colorectal cancer and endometrial cancer, but there's also an increased risk of ovarian cancer and gastric cancer. And as I said before, if you want more information, A Beginner's Guide to Lynch Syndrome, it's a kind of sister leaflet on the Royal Marsden website, is really, really detailed. It's an easy read, but it's very, very detailed. I suppose things for you guys to look out for in your patients, any young colorectal cancers or young endometrial cancers, so people being diagnosed under the age of 50. Also look out for if there's colorectal cancer, as well as any of these other types of cancer in multiple generations of a family. Be thinking, could this be Lynch syndrome? Should I be sending this family for further investigations? And at the very end there, again, as David had mentioned, people who have a faulty gene associated with Lynch syndrome and develop cancer, their tumours show very specific markers. So again, if a pathology report comes back that shows that a colorectal cancer in one of your patients has high MSI or has loss of staining in IHC, we'd be interested in, there's a good chance they might have Lynch syndrome. They should kind of have a chat with us. I'll not stick on the risks too much, but again, back to who to refer, young patients, patients with loss of staining. I suppose towards the end here, there's advice about what we know is that if you've got a very close relative or 2 or 3 close relatives who've had bowel cancer, there might be an increased risk of bowel cancer for patients, even if we're not talking about Lynch syndrome. So again, if you wanted a cancer risk assessment for patients, if they've got a very young colorectal cancer, a parent, a sibling or a child who's been diagnosed with young colorectal cancer, or if there's 2 close relatives or 3 close relatives at different ages, we would look into that and we could give you advice. I'm not sticking this too long. Kind of bringing it back to, I suppose, my role and the new clinic in Blackrock. VHI are covering genetic testing for certain cancer conditions, primarily BRCA1 and BRCA2 and Lynch syndrome. It's covered under certain plans, and you can find out more about that on their website. Again, if patients are coming to us to be seen, it's good for them to check if they are covered for the testing. I suppose the other thing is that not everybody who is covered under VHI for the testing will actually meet the clinical criteria for the test. So again, just for patient expectations, not everybody that walks in the door will get genetic testing or will need it. And again, we're also accepting private referrals for both cancer, hereditary cancer risk assessment and genetic testing as well. And again, you can pop the referrals to Professor Gallagher at Suite 16, and my contact details I'll leave up. And please feel free, if you have any questions about any of this, or again, if there's any specific questions about a family that you want to ask, you can get in touch. Oh, sorry.
Thanks very much, Owen. That was brilliant. And David, can I just ask you 2 questions, please? I have several families with BRCA, and I want to know who within those where the mother has it, what the kids are, like 20, 22, 20, 18, 14. What age should I get those children screened at?
That's a very good question. So in general, we wouldn't offer predictive testing to anybody under the age of 18. So we don't test children for either Lynch syndrome or BRCA1 or BRCA2, and that's primarily because the risk associated with false in those genes doesn't come until people are older. So there's no risk for children, so there's no kind of imperative to test them. I suppose the other side of the coin is that it's good for people to be at an age where they can make informed decisions about whether or not they want to know do they have a mutation in one of these genes, and it can be part of that conversation as well. In general, for women with BRCA1 or BRCA2, we wouldn't start extra breast screening until probably the age of 30. So that on one hand, that gives people a bit of time to kind of make a decision and see, is that the right thing for me to do? But for some people, they really, really need to know. It's the not knowing or the uncertainty about whether they have the faulty gene or not can be the killer. So some young women in their early 20s decide that they do want to know this information. My point of view would be that's their decision. They should be informed about the risk. at an appropriate age, and then it would be their decision to make, well, what is the right decision for me and when should I do this? And again, coming to see a genetic counsellor, a genetic nurse, just because you walk in the door doesn't mean we're going to take blood from you that day and do a test. We'll talk to you about all the different implications for you, particularly at that stage of your life you're in, and say, well, is this the right thing for you right now? Or do you want to come back when you're that little bit older, or when you're starting a family and things like that?
I think I'd emphasize that. I think you have to individualize it based on the person. Some 18-year-olds really want to get this done. Some 18-year-olds are nowhere near being at a point in their life that they could contemplate any of this. I tend to refer 25-year-olds to my breast surgery colleagues to learn how to do a proper breast exam. So I like to see them testing sometime between 18 and 25. But as Owen says, in most families, we don't start screening until 30. The exception is if there are some very early breast cancers in the family. So we have some BRCA families that there are breast cancers at 23, 24. We'd like to test those women earlier because we will start screening earlier in those families.
I suppose as a GP, our dilemma is often we have the mother who has the gene. She's 50. We've got the kids who are 22. The mother doesn't want to tell the children it's a genetic form of the disease because she doesn't want this sword of Damocles hanging over the kids' necks.
Yeah.
And yet, they're also our patients.
Yeah.
So should we be saying to them, look, I know your mother, I feel we should be saying to them, you perhaps should be screened for this because unfortunately your mother has a disease and she has a gene. So it's a tricky one for us.
Generally, the mother cannot have tested, certainly not in our clinics and not in Crumlin, unless she has signed consent for other family members to acquire that information. So that's part of the genetic testing consent in this country. Once they're 18, to be very honest, that's not a situation we come across that frequently anymore. I think once people understand that there are plenty of cases out there like the young woman with metastatic breast cancer that was 100% preventable, and once a parent understands that they have unlocked the power to harness that ability to prevent, there are very few parents that wouldn't want their child to test, I think, once they fully understand it. And once they also understand that there are no real negatives. Yes, your reference to the sword of Damocles is relevant, but ultimately these are life-saving tests. People can't be discriminated against. I have seen occasionally where parents have withheld this information from children, from adult children, and the discord that arises from that in families is oftentimes huge. So I would really encourage parents to share that information with their children, and if they don't, you can always contact us because we can generally confirm that there is a consent form that has been signed to allow that information to be shared with family members.
I think one of the things that I'd actually meant to cover on the talk and didn't get to was within families, within genetics, there can very often be this sense of guilt. This guilt that I have something that I may have passed on to my children. And particularly in cancer genetics, it's more you're dealing with the parents' worry. And actually, when they tell their children, first of all, their children tend to be more resilient than you give them credit for. But again, since Angelina came out in 2013 to talk about it, people are much, much more aware of this kind of thing. And actually, most young people can see the positives in it. They can see, well, there's steps I can take to reduce my risk. And so the silver lining that a lot of people take away from predictive genetic testing is that they're getting the chance that their mother or father or loved one didn't get. You know what I mean? They're getting the warning, and there's things that they can do about it. Now, I think we probably don't see a lot of the families who decide that they're not telling their kids because they don't ever come through our door. But if there is particularly difficult cases, that's where sitting down with a genetic counsellor for half an hour, 40 minutes, talk that through with parents and actually get them to get, a lot of the time they will have misinformation or there'll be something holding them back, and actually having spoken it out, they can come to a conclusion that probably is the best thing to do.
Professor Gallagher, just with regards to the legislation that's in place to prevent discrimination, are we able to say to patients that there's no requirement for disclosure, or do they still have to disclose but that no discrimination is going to actually...
No, there's no requirement for disclosure. And when you do a medical now for a mortgage, they should ask, and in my experience they do ask, have you seen a doctor for anything recently other than genetic testing? So there's no requirement.
Thank you. Could I just ask the procedure then? So if we've 3 generations of, we've 4 say we've grandmother dead, great-grandmother dead of breast cancer, grandmother is 80, breast cancer, daughters and now granddaughters. Do you need the 80-year-old's blood, she had breast cancer, to test for BRCA, or can it come from the generation who hasn't had breast cancer maybe yet?
It's a very good question. So we want to test someone who has had cancer, and preferably we want to test someone who has had cancer at a younger age, because even in these BRCA families, you get women developing breast cancer sporadically for the same reason that other people who don't carry hereditary predisposition develop breast cancer. So one of the things that Owen and I do is we select the best person in the family to test the person most likely to carry the BRCA gene. And I think the really important point embedded within your question is oftentimes there is only one individual living in a family, and they can be quite elderly. They may have had their breast cancer in their 40s but are now in a nursing home in their 80s, and that's the person we need to get blood from to unlock the information for the next generations. So it is a person with cancer that we do the initial test on, preferably someone in the family who has been diagnosed at an earlier age.
Sorry, I'd just like to ask, when is negligent presence in primary care? When do you say negligence has occurred?
I don't know. I don't think that's ever been tested in the Irish courts in primary care. I think, I guess my concern is that families would be falsely reassured that they don't need to test, or part of the story I didn't tell you about that 36-year-old woman with the 3 kids. She had discussed with her GP whether she should test in her early 30s, and she had had difficulties conceiving, and he had reassured her that there was time to wait, and that's incorrect reinsurance. But advice that was given for all the right reasons. But I think, yeah, my concern is that in primary care that people won't be referred when they should be, and it's primarily that concern arises from missed opportunities to prevent people dying from cancer. But you know, I think I showed you one court case. There was a second one earlier in the year, and there is one solicitor in Limerick who is very actively pursuing this across the country at the minute.
Sorry, this question just picks up from what you mentioned there in terms of screening, or if there's oncology protocols now in clinic, because communication back to us may not be clear. If there is a new index case, is there a mandatory follow-on to your service, or ultimately will it come back to primary care that a patient will need to be followed on with?
Sorry, I missed that. Is it that you guys will be responsible for doing the follow-on?
Or is there a performer within oncology departments at the moment that if there is a new index case that a family will be followed through? Or is it our responsibility as well to clarify it with the patient?
Yeah, that's a very good question as well. So we can't reach out to family members and invite them into our service. So what we do is we give these information leaflets to the index case and ask them to disseminate them among the family and seek a GP referral then into our service. And that's the best we can do.
Sorry, there's another question over there.
Just 2 points. You would not advocate prostate screening generally. It would be okay. You wouldn't generally advocate prostatic screening because it wouldn't be cost effective, I'm quite sure. But you would advocate it in BRCA cases, presumably. That's number one. And number two, in BRCA families, what about the contraceptive pill in young girls that have not, that haven't been tested? There's a BRCA family history maybe somewhere in the past. But what is the role? There's so many studies in the past that show the contraceptive pill was not very conducive to prevention of cancer. In fact, it may increase the risk of breast and ovarian cancer.
Okay, so I think there's three questions in there. The first one on prostate screening in BRCA carriers, absolutely, it works. They should be referred from 40 years of age. The oral contraceptive pill does not increase the risk of ovarian cancer. There have been conflicting results in the breast cancer example. So there's been some reports showing a slightly increased risk of breast cancer. There have been others showing no increased risk. If there is an increased risk, it's very, very tiny. And in the young women that I look after, I think it is more important to prioritize contraception in them as long as they're in a breast screening program. So that is, that's the advice I give to them. That's the international standard of care looking after these families. Prostate cancer screening, James is probably better qualified than I to answer that, but it's an interesting question. So you made the point that PSA screening is not cost effective. And you're probably right, but PSA screening is as good as mammographic screening from a population perspective for breast cancer. Yet we have embraced mammographic screening. The Swedes recently tried to cancel their population mammography program, and they had to reintroduce it because there was such an outcry from advocacy groups. So I think in BRCA carriers, PSA screening should definitely be used. In familial prostate cancer, so where there are a number of cases of prostate cancer, PSA screening is probably of benefit too. In the general population, it's probably not of benefit because there is risk in that there's over treatment of patients, but no more so than with mammographic screening of women.
Just to come in briefly as well, on there have been some studies, particularly in the effect of oral contraceptive pill in BRCA 1 and 2 women, and actually the oral contraceptive pill can have a protective effect against ovarian cancer. So it has been said that actually it's safe for these women to take because, as Dave said, the jury's out whether it does cause an increased risk of breast cancer, but any slightly increased risk of breast cancer is thought to be kind of counterweighted by the protective effect on ovarian cancer. So it's safe for young women to take that if they are a BRCA carrier. And on a slightly similar but different issue is that sometimes what we see as well is BRCA women who have risk-reducing bilateral self-oophorectomy, they can have HRT after that, even though they, traditionally we believe HRT causes an increased risk of developing breast cancer. If they've had their ovaries removed before the age of natural menopause, it decreases their overall risk of developing breast cancer, and then HRT is safe for a short period of time.
Do you know whether, is it routinely done, the genetic testing on surgical specimens that are removed from, say, colorectal cancer patients, or is that only in suspicious cases like very young age of onset? And the other thing is, for people who don't have VHI, how much does it cost to to do an initial consult for genetic counselling, please?
Okay, so the surgical specimens of bowel tumours are all now routinely tested for proteins that are expressed looking for Lynch syndrome, but they don't have a genetic test on, so it's just the protein that's tested, not the gene. Second question was what it costs if people don't have VHI. So the clinical consultation for myself and Owen's time is €250, and then there's a whole spectrum of cost for a genetic test. The one that the VHI cover in Birmingham or Manchester currently is about €1,500, depending on the exchange rate, but it can range from €500 up to €2,000 for the lab costs of a genetic test.
Thank you.
We just got information from that Irish Life will shortly be covering some of the genetic tests and genetic counselling. Is that correct?
James, the CEO of Blackrock Clinic. Yes, that's correct. So all of the other insurance companies now are following the VHI's lead, which I have to say I've had to congratulate the VHI for doing it. But Irish Life Healthcare over the next couple of months will be covering it at Blackrock Clinic, and I believe Leia Healthcare are also interested in also covering it.
Okay, so thank you everybody, and thank you to all the people who joined us on webinar as well. You can go and get dressed and have your shower now. The rest of us are all ready for the day. Thanks very much to the Blackrock Clinic for hosting us all, and most especially to our speakers, and also to our audio men for looking after us so well. Thank you, gentlemen. Really, really interesting speakers. Thank you so much, all of you, for giving us your time. Bye-bye. Just as the audio man, apologies.
The audio man is fine, yeah.